The National Center is delighted to partner with the New England Addiction Technology Transfer Center to create a learning community to highlight the issues facing child welfare, substance use treatment providers, in the courts. The learning community leverages knowledge and innovation in practice and policy approaches from both the National Center and the New England ATTC. The National Center was established in 2002 to provide information, consultation, training, and technical assistance to child welfare, court, and substance use treatment professionals to improve the safety, permanency, well-being, and recovery outcomes for children, parents, and families. Both the National Center and the New England ATTC events and resources will be shared at the end of this presentation. With that, I would like to introduce Dr. Sarah Becker, the Evaluation Director of the New England ATTC that oversees regional initiatives to support the prevention, treatment, recovery for youth affected by substance use disorders.
Hello, everyone.
Sarah?
Hi, everyone. On behalf of the New England Addiction Technology Transfer Center, I just want to thank Melissa and the rest of the team at the National Center for this great opportunity to collaborate on such an important webinar series for the New England region. The New England Addiction Technology Transfer Center, otherwise known as the ATTC, was established in 1993 by SAMHSA, and we're part of a national network that's comprised of 10 regional centers that serve all 50 states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and several Pacific Islands. We also have 4 national focus area centers that address priority areas identified by SAMHSA, such as promoting the screening, brief intervention, and referral to treatment model, and addressing the important needs of underserved populations. And across our region, our activities are facilitated by a national coordinating office. Our network mission is really threefold, and that's first to raise awareness and skills of the workforce that treats those individuals affected by substance use disorders. Second, to accelerate the adoption and implementation of those practices identified as supported by research evidence. And third, to foster regional and national alliances among diverse clinicians, researchers, policymakers, funders, and the recovery community. And so this collaboration with another national center is really exciting for us as part of this effort. Moving to the next slide. This webinar series was really the outgrowth of conversations with the National Center that started about a year ago when jointly our organizations wanted to address the needs of families in the child welfare system affected by substance use disorders. So we conducted a survey of key stakeholders in the New England region to try to determine the greatest areas of training needs facing those providers who work with families in the child welfare system affected by substance use disorders. Our survey was answered by 63 respondents across all 6 states in our region, and participants could select up to 3 responses to a question about their areas of greatest training need. And as you see here, trauma-informed approaches to care was the response selected most often by our participants and was actually selected by over 70% of those who completed our survey, which really highlights the value of this important topic for our region. So moving forward, today's webinar agenda really builds upon this needs assessment and will next shift to a discussion about the National Center's Trauma-Informed Care Assessment Project, which will be led by Amanda Kellerman from the National Center and by Dr. Vivian Brown, who's the founder and retired CEO of Prototypes and a consultant at the National Center. And following that, we'll learn about the process that the Institute for Health and Recovery uses to help organizations enhance their capacity to provide trauma-informed care. And that discussion will be led by Dr. Laurie Marcus, the Director of Trauma Integration Services at IHR. Then we hope to leave some time for questions and answers before a brief review of upcoming regional events and an overview of some regional and national resources. So without further ado, I'm delighted to turn it over to Vivian and Amanda.
Thank you so much. It's a pleasure to be talking with all of you this morning and afternoon. Excuse me, I'm in California. I wanted to start with some background on trauma and trauma-informed care. And you can see that many of the children in child welfare systems have a parent in need of substance abuse treatment. Substance abuse and trauma and child maltreatment are really co-occurring multi-generational problems, and we really feel that unless we meet the needs of the parents, we really are unable to meet the needs of the children. And so when the focus has been on the children and not the parents' trauma as well, we were not doing the adequate care that we needed to do. The definition of trauma that you'll see up on your screen, this is from SAMHSA, Substance Abuse Mental Health Services Administration, and really describes that trauma results from an event or a series of events that is experienced by the individual, and that it's really the individual's experience of these events that determines whether it is traumatic. I wanted to share with you two major studies that are quite relevant to defining trauma and trauma-informed practice. The first is the Adverse Childhood Event Study, which many of you may already know, but a very important study because it was done by Kaiser Permanente and the Center for Disease Control, and was one of the largest scale studies of the influence of traumatic childhood experiences on health. And over 17,000 people were a part of that study. And what is important is they interviewed these people when they were in approximately their 50s, early 50s, and then could look at the impact on adverse childhood events, which you're seeing on the screen, and their health. So you can see substance abuse is one of the leading percentages there. And if the score of the person was 4 or more, everything became more likely. You can see attempted suicide, drug use, alcohol. But it also allowed for the information around serious health issues, including heart disease, cancer, diabetes, etc. And that's why this study became so important, because it really was the major study to show that link between early childhood events that were traumatic and later health disorders. The trauma exposure, we now know from research, is almost universal. In adult parent samples of those parents who, of course, children are in welfare, child welfare, and in the drug court populations. And for those populations, figures range up to about 91% who've experienced at least one traumatic event. And on average, they've experienced 6 different types of events, which is extremely important. The other study that really led to the dissemination of trauma-informed care, as well as trauma-specific interventions, was the Women with Co-occurring Disorders and Violence study. And this was a 5-year study funded by SAMHSA. My program was part of it. Dr. Markov's program was part of it. And so we have intensive knowledge about this study. There were almost 3,000 women enrolled in this study. And it really showed a number of things that were very important for all of us to know, that integrated counseling, meaning we integrate mental health, substance abuse, and trauma issues. If you do that in all the sessions and in your interventions, it was more effective than, and no more costly, which is important, than services as usual. And the other things that were really key lessons were that the collaborations between those with lived experience, because every one of our sites had peer staff, and these peers had substance abuse, mental illness, and trauma, and it really increased the quality of the services and the research. We also used group environments and interventions to help restore the trust and promote healing, which was extremely important. And the last piece, I think, deserves real mention, which is that we really learned the differences between the trauma-specific services, which are those interventions like Seeking Safety or Beyond Trauma or TREM, that focus directly on helping the client understand what happened to them and how it impacted them, and to learn coping skills to reduce the impact. Trauma-informed practice, it takes into account the role and impact of trauma and violence in all of the lives of people we are touching. So it may not just be in mental health and substance abuse and emergency services or crisis intervention, but in schools and in criminal justice and education, everywhere, that the trauma-informed practice really accommodates the vulnerabilities of trauma survivors and allows services to be delivered in ways that avoid triggering trauma memories or re-traumatization. So the responses to traumatic events, most of you have probably heard about fight or flight. If you're looking at someone and they are angry at you, hostile at you, cursing at you, that would be the fight response. Flight response, of course, is that the person doesn't follow through on their court plan or their treatment plan or doesn't return to treatment or court. And freeze, the individual may not even be able to communicate what they're feeling, and we see this mostly in children who really, when very young children can't really fight or flee, they're going to show the freezing response. And all of these responses affect an individual's response to treatment and to courts, etc. We know that traumatic events shatter trust, and particularly when the trauma has been caused by another person. So if your trust has been shattered, you're not going to trust someone even if they say they want to help you, which is all of us. We're saying we want to help you, and the person is hearing, you're going to hurt me. Particularly because in the case of trauma survivors, power and control were taken away from them. So the individual is in a state of heightened alertness, what we call hypervigilance, and sensitivity to possible danger. In this state, minor or even neutral stimuli can be misinterpreted as threatening. I mean, even if you reach out to the person, this can be threatening and can lead to avoidance or withdrawal or aggression. So it's important that we understand that trauma is the expectation, not an exception. And if you see a client with any of these responses, or if you're thinking about them being non-compliant, we say, think trauma first. So the importance of the trauma-informed care is, again, because everywhere we looked in the research, there was high prevalence of trauma and the co-occurring problems of substance abuse and mental health. And we really need to maximize safety and reduce possible re-traumatization. If we do that, we improve retention and services and really improve outcomes. We know much more about trauma now, so that we know in some instances we inadvertently may have re-traumatized people. And I usually use the example of seclusion and restraint in psychiatric care. We now know that that is re-traumatizing for most people. Now you're seeing the 6 principles of trauma-informed care, SAMHSA's document that recently came out, where we have safety and trustworthiness. I'm sure you all, again, safety know that number 1 is safety. The second, of course, trustworthiness and transparency, is that we really want to ensure consistency and predictability for our clients. And, of course, peer support being extremely important for trauma-informed care. Collaboration and mutuality, again, we want to collaborate not only with our clients, we want to collaborate with our staff, and we want to collaborate with other agencies that may also be seeing our clients. And at the empowerment, very important, again, that clients have a voice and share in decision-making, because, again, trauma survivors have lost power and control when they were traumatized. And the last, cultural, historical, and gender issues, makes it extremely important to bring up historical trauma as an extremely important concept. We know there are populations, Native American and African American populations, with historical trauma and need to be, of course, understood and part of the treatment as well. So the background about our trauma assessment that Amanda is going to talk about in a few minutes, I wanted to give you some background on this, which is that Roger Fallon and Maxine Harris, again another part of the Women with Co-occurring in Violence study, they, as part of that, developed an agency self-assessment and covered the 5 core elements. You notice that cultural issues are not there because that was assumed by them that it should have been part of all client-centered care. This is for trauma-informed. And I adapted the assessment into a systems walkthrough that allows teams, staff and administrators and peers to move through the system processes through the eyes of the client. And some of you who have participated in NIATEX, which was that national initiative for addiction treatment improvement, may know about walkthroughs, but it really gives you a sense as you walk through an agency or you walk through the entire system, which we have done with family drug court systems, to understand the experience of care through the client's eyes. You're really looking now through a different lens. And it helps the staff members walking through to also understand how they may inadvertently reenact the trauma dynamics, and to really look at ways where we may be triggering the person and how to improve the system process. So the trauma walkthrough, as I see it, is a mutual information gathering strategy. It is not a judgment. It is not an audit, which we all dislike, but it is where we all walk through the agency or system looking through the trauma lens, understanding how we may be re-traumatizing clients. We may be triggering them. And then from this walkthrough, training and technical assistance grow out of that assessment and action plan, which makes it part of the whole team to decide what kinds of trainings they want in trauma. So the core question of the walkthrough is, could this practice or procedure or design element upset or trigger the client, the participant? And I just want to give you a couple of sample questions for the walkthrough, but all of the whole walkthrough questionnaire is part of the in the reference section in the article written by myself and Roger and Maxine. So just a few questions. When you walk up to the site, does it feel welcoming or unsafe? What does the waiting room feel like to you? How many people are there in the room? Filling out the intake forms, how does that feel to you? Were you given any choices with regard to your treatment, when you would be seen, by whom, gender of counselor, etc.? Well, all the questions are there for you. And at each step of the walkthrough, we have everyone identifying possible triggers. And then for each trigger, brainstorming possible changes that can be made. And the team, we leave them with a preliminary action plan, and the team can then add to it as they go along and look at what they want to do, how they rate the greatest risks, how doable is something, and they then have an action plan which may take them a year or two to get through. And I'm going to now turn it over to Amanda Kellerman.
Thank you, Vivian. Hi, everyone. My name is Amanda Kellerman, and I am the project manager for the National Center on Substance Abuse and Child Welfare. And it was my pleasure to partner with Dr. Brown over this past year, through the National Center to provide this trauma-informed care walkthrough project. So I'll do a little bit of background on the project, and then we'll get into some of the findings that we came across in doing this project. And I really hope that this part of the presentation can give you a really clear example for what trauma-informed care looks like. We heard from a lot of you that, and we heard from a lot of people on site as well, that that's really the missing piece right now. There's a lot of training out there on trauma right now. A lot of people have a great understanding of how trauma impacts a family, but what's missing is what does that really look like? So we hope that today we can give you some clear examples between my part of the presentation and Dr. Marcus' part to really to see how trauma-informed care really looks. So we'll move ahead here. There we go. Quick background. So this project, the Trauma-Informed Care Walkthrough Project, was funded through the National Center. We partnered with Dr. Brown as a consultant, and we selected 5 sites over this past year. We actually facilitated the walkthroughs last summer. We did do a selection process to select our 5 sites that we worked with, and you can see the selection criteria here. We did an outreach, and sites submitted a letter of interest and indicated to us that they were ready and willing to participate in this project. We did select 5 sites from across the country. We had both rural and urban sites. The key piece was that we wanted our sites to be cross-systems collaborations. So we chose sites that actually had a family drug court at the heart of their collaboration, but they involved substance abuse treatment providers, child welfare services, the family drug court or family treatment court, as well as some other community partners in some instances as well, such as mental health services, housing, some other partners. But the core were the family drug court, the substance abuse treatment, and the child welfare component. So we were looking to make change really across systems here. So in preparation for the walkthroughs, we got the team together on a planning call, and we started by getting every team member who was crucial to the project together and talking through the process. We developed the agenda for the 2-day visit, and then we also completed a baseline survey. So I'm going to get into a little bit of the findings here of our baseline survey. Our intention here was to get some baseline information for where the sites were currently at. So we wanted to gather what types of trainings they had received, what type of funding that the agencies had for trauma-informed practices, what types of trauma-specific screening, assessment, and intervention they were doing, and then the different types of policies and practices that the organization had already had in place related to trauma. You'll see here the breakdown of who responded to this survey, and it was actually done, we asked the leaders from each team to send it out to all levels of their agency. So we had, for child welfare services, for instance, we had everyone from the frontline worker all the way to supervisors to upper administration. So lots of variability in who completed it. So I wanted to go over some of the findings here because they're really interesting, and they gave us a snapshot of where the field was at with regards to trauma-informed care. A really interesting finding was that, as you'll see here, 92.4% of respondents indicated that they understand how trauma impacts a person and a family. So as I mentioned before, and we saw that on site, everyone seems to understand trauma and how it impacts their engagement in services and that process. Where the gap is understanding how to provide trauma-informed care and trauma-informed services. You'll see only 50% agree that they had an understanding of that piece. So that gave us a clear indication that on these walkthroughs we needed to focus really on that how-to piece. Again, you'll see here 60%, nearly 60% indicated that they knew the difference between trauma-informed care and trauma-specific services. And Vivian already touched on this a bit. That was another piece that we focused on when we were on site. You'll see nearly 70% have received training on the topic of trauma, and you all on the phone may agree today that that's something you see in your area too. You've seen presentations at conferences and webinars on trauma. But less people had received training on the trauma-specific interventions. With regard to screening and assessment, you'll see that nearly, or just over 40% indicated that their agency does conduct a screening for trauma. So this was a gap that we identified as well, that many providers and agencies aren't asking questions to their clients to see whether they have had experiences of trauma. So that indicated to us we needed to get to that as well when we were on site. With regard to trauma-specific interventions, you'll see about 40% agree that their agency currently implements one or more evidence-based practice. You'll see below the top 3 interventions that people indicated that they were using were seeking safety, trauma-focused cognitive behavioral therapy, and parent-child interaction therapy. Those were the most commonly reported ones that were reported. That was a little bit about our findings in the baseline survey. And now we'll get into the trauma-informed care walkthrough process. So as I mentioned before, the sites completed a 2-day walkthrough, and it was led by Dr. Brown, myself, and another National Center staff who rotated through each visit. The visits each began with a briefing session, so we got the entire team together. What was most important for us was that we had a leader from each system present for the entire walkthrough. So as Vivian mentioned before, the real value to doing the trauma-informed care walkthrough is that the whole group is able to really slow down and take a step away from their daily practices and their busy lives of meeting with clients and all of that to really walk through the agency together as a group and identify from the eyes of the client where there could be potential trauma triggers. So we really stressed to the group that we wanted each key player to be there for the entire visit. It also was beneficial to have, for instance, a substance abuse treatment professional walking through the child welfare agency so that they could see across the system, maybe from a different perspective, what other trauma triggers are there, visible, observable there in the site. We also completed each walkthrough with a debriefing session where Vivian and I went over what we saw in the walkthrough. We identified the trauma triggers that we had observed, as well as some potential solutions. So maybe as we walked through the system, we saw, oh, that's a trigger, but then also identified, well, this could be an easy fix, or maybe this is a solution that could get to solving that trigger. And then lastly, we developed a preliminary action plan based on those findings we presented at the debriefing session, and we presented that to the group. From there, it was up to the team to take their preliminary action plan and move forward with creating steps and creating change in their organization based on their priorities. So I'll get into some of the findings, and as I go through these next slides and present some of the most commonly identified trauma triggers, I invite you to think about your agency, your organization. Think as I walk through these bullets, are any of these triggers present in your organization currently, or maybe some of your partners? I will be getting to some of the solutions that sites have come up with and have already implemented to respond to some of these triggers. So we will get to that as well. But first wanted to go over what the most common triggers were. So based on those preliminary action plans, we analyzed that qualitative data and pulled together the most common themes here that we saw across all sites. And interestingly, there were some very common things that came up across the sites. So no matter urban, rural, across the country, there were things that were present in many places. So that's what we'll be presenting on here. I've pulled them out by theme. So you'll see here this first slide is on safety and physical space. So here are some of the examples of the trauma triggers that we identified on site. You'll see unwelcoming buildings. We experienced some hallways and rooms that felt very dark, cold. We had actually an interesting and kind of funny story was we had, in one of our walkthroughs, had invited our peer the group had a peer recovery specialist, and we had invited him to join us on the walkthrough, which was a very beneficial experience to hear from someone who had gone through the program, had survived his own trauma, and had also been a graduate of the program. And he felt very comfortable to share what he had experienced. And we walked into one of the intake and assessment rooms, and he blurted out, "This room feels like a closet." And we all kind of laughed, but then looked around and went, wow, it really does. So hearing that peer's example and statement there really brought it to life. Armed security guards. That was something that came up in a lot of our walkthroughs. There are many situations where there are security that we can't get away from, for instance, walking into a court building. But we identified some security guards that maybe were triggering situations. So that was one of the triggers, as well as some echoes and loud noises in rooms, flickering lights. So paying attention to those kind of little things around the building that can impact a client who's experienced trauma. Lack of artwork or trauma-triggering artwork. Staff desks with was a big one that came up on a lot of the visits, where we walked into offices where clients would meet with their clinician or with their worker, and either the client's backs or the staff's backs were facing the door. And for someone who's experienced trauma, if their back is facing the door, it can be quite triggering if they're not knowing who is coming in behind them. As well as if staff are blocked in behind their desks, if they've experienced trauma themselves, may feel a little bit closed off and blocked in and unsafe. So that was one that we identified in almost, I think, all 5 of the walkthroughs. Another was not enough space for clients to sit in the courtroom, and this was in the family drug court. Maybe clients walked in and it was really loud and there was a lot of movement and shuffling and loud noises, and we felt that that could be triggering for some clients. Moving on to the intake and assessment process, one thing that we noticed at every walkthrough was that there was quite a bit of repetition across assessment and intake forms at every agency. So with the partnerships that we worked with, we had clients who will be involved with the family drug court, the substance abuse treatment agency, child welfare, among other partners. And we noticed in looking through their intake and assessments that they were being asked the same questions at every agency. Of course, the limitation is that there are some forms that are required either by the state or that each agency must complete. But there was quite a bit of repetition for information that maybe could have been cut down to minimize the need for the client to repeat their trauma story every time. This may make the client feel unheard, maybe lose trust in the agency, kind of that feeling of, why aren't you listening to me? I've told you this before. The lengthy intake procedures, that was another big one. So clients would have to complete 2, sometimes 3-hour assessments with little breaks, or maybe not a chance to go outside, maybe some food. Another one was with a lack of child care. The kids sometimes were with the parents during those assessments, so that could pose a challenge as well for that lengthy procedure. Lack of screening and assessment questions was also a trigger that we identified. Again, it kind of paired back with our results from the survey in that not many agencies were screening for trauma. So we had talked with them about adding a few questions on their intakes to get to some of the trauma experiences. Lack of clarity and inconsistent processes was also there. And this can help, can make the client feel like they don't know what to expect and feel a little bit of lack of control in the situation. So that was another trigger we identified. With trauma-specific interventions, there were a lack of trauma-specific services for children and parents. So again, partnering or reflecting what we found on the survey, some communities did have some really wonderful trauma-specific services. So we had some that were implementing seeking safety and some other really great evidence-based practices. But still, there was a lack of services for that. What was really clear for us was a lack of partnership with mental health services. They were often not at the table at all with these partnerships, which posed a real challenge for providing trauma-informed, trauma-specific services for these clients. Many of the partners didn't know what mental health services were available, and clients didn't have access to these services. So that was a big one that came up for us when we were encouraging some change, was to get mental health at the table and improve that partnership to increase the amount of trauma-specific services that would be available to the client. Within the family drug court setting, and this could generalize to other court settings, any type of collaborative court, we noticed a lack of consistency in responses. So that would be the incentives and sanctions that are given to the client. A lot of times there was no clear messaging about what responses were given, and this can help have the client feel like they don't know what to expect. They might lose trust in the team because maybe one client is receiving one incentive, and then they themselves maybe aren't receiving one for the same behavior. So that inconsistency can be a trauma trigger for clients. Triggering sanctions. Of course, there are some situations where jail time is given as a sanction, and some courts, that's part of their protocol, and that's okay, but we encourage sites to think about the sanctions that are given and think about how they could be triggering for clients. As well as thinking when an incentive or a sanction is given, thinking about what behaviors might have precipitated the action situation that required a sanction. So, for instance, let's say a client has not shown up for drug testing. Maybe thinking about, is there something triggering in that drug testing situation that is encouraging the client not to go back? If they're triggered and they're not wanting to go, rather than just give a sanction and not investigate further, maybe it's about having a conversation with the client to really hear about why they haven't been going. Maybe they're being triggered by that situation. And again, as Vivian mentioned, think trauma first. So when there are behaviors that happen in the courtroom or in any system, think trauma first before you give a response to that behavior. Always best to consider the trauma. This ties in well with the drug testing space. So at a lot of the agencies that we saw that do the urine testing on site, we noticed that we got to peek in their bathrooms and take a look at where they were doing the testing. And we noticed that many of the bathrooms were in high traffic areas. We had one site, for instance, where the bathroom they used for testing was in the middle of the cafeteria area. It was a residential treatment center. So this could be triggering for a client where they feel a lack of privacy. They feel that other clients may be hearing or listening or watching what's being done as they go into the bathroom. Many bathrooms were uncomfortable, a little bit small, maybe unwelcoming, where not enough artwork, not enough comfort in the bathroom, not enough space. So for someone who's been triggered and the drug testing experience or the urine testing, if someone is standing right over you, watching very close to you while you're doing that, it might be triggering for you if you have had a history of sexual abuse or other types of abuse. So with drug testing in particular, this is one where we know we can't not do it. We have to drug test in certain situations. So this really came to how do we address the clients in this situation, and how do we really take into consideration what would make them feel comfortable. So it's maybe even a matter of talking with the client, saying, I know, I have to do this, but what might help you feel a little bit more comfortable in the situation? And maybe the client will say, can you just step back a few feet? Sure. That's an easy change that can be made of just addressing with the client, having that conversation, what would help you feel better. Client choice and empowerment, this ties in with that one. We talked a lot about offering clients choice in the program. And this was triggering for some of the staff. They mentioned, well, how do we make sure that the clients aren't taking advantage of us if we are offering them choice? And we noted a lot of times this choice is small things. It's offering the clients choice that maybe between a counselor, or offering clients choice of a treatment group, which group to start at. It's not always big things, but it's finding little areas to empower the clients and give them choices. The last trauma trigger that we identified in nearly every agency was secondary trauma for staff. So really this came up a lot, where staff were concerned about, or supervisors were concerned about their own staff with either their own experiences of trauma or just feeling traumatized by the work that they're doing. There was a lack of physical space for staff, to decompress after difficult meetings, so no real safe space for staff to go to have a few moments of quiet. As well as front office and security staff, so maybe staff who really don't have any training in trauma, they were identified as feeling anxious and not understanding when clients come in, feeling triggered. So that was another staff trigger that we experienced. So I'll jump ahead now to some of the changes that have been reported so far. That way we can highlight for you what can be done about some of these triggers. So if as I walked through these steps, you said, oh, well, I have that, or I have that in my agency, now you can hear some of the examples of what's been done to mitigate some of these traumas, or some of these triggers, that we experienced. And we've reported these with the sites after 6 months. So they're still in progress. They're still working really hard to get to some of these changes. It takes a long time. But these are what we've seen so far. I've separated them out by the domains of trauma-informed care that Vivian went over. So we'll start with safety here. 2 of our sites reported rearranging their staff offices, so already moved their desks around so that staff didn't feel blocked in, distracted by noise, or having their backs to the door. 2 sites reported changing their drug testing bathroom spaces. So they moved to more private areas. We've heard of them adding artwork up on the walls and making the bathrooms just feel more homey and comforting. all sites noted that they were working on adding artwork to the walls throughout the agency. So some of our experiences were hallways that looked like hospital hallways, and we've heard from all of our sites that they've already been working on getting some great artwork. In some cases, artwork from clients, which is really wonderful as well. One site has already created a safe space for their staff in Child Welfare Office, which was really exciting for us to hear. I think they're calling it a Zen room at this time, or a wellness space, but a place for their child welfare staff to go and have a moment to decompress. 2 sites are already working on implementing a training for their front office staff and security guards. They're actually doing trainings for all levels of staff on kind of a trauma 101, hearing about how trauma impacts a person. And then one site already noted that they're using peer specialists to greet individuals at the security screen. So as I mentioned before, you can't always get away from having security there, but maybe having a peer specialist meet your clients at the door and help walk them through, help them feel warm and comforted as they walk through that triggering situation. As far as trustworthiness and transparency, one site has already made it a priority to develop information sharing agreements. So this is getting at the challenge that we identified of that repetition across agencies of the intake and assessment questions. So they've already started gathering as a team, and they're looking at each system's intake and assessment forms and identifying as a team what agencies can cut down on certain questions. From there, they're developing an information sharing agreement to put down on paper what they're specifically going to be sharing then. So they have to agree upon, if I'm not collecting this information, I trust that you will be collecting it, and I trust that you will share it with me. So that will help minimize that duplication. And all sites have noted changes in their family drug courts to the incentives and sanctions that they're using. One is implementing a tiered list of rewards and sanctions to ensure consistency so that clients know exactly what they'll be getting depending on their behaviors. With peer support, we have sites working on securing paid positions for peer mentors. As well as one site, this was really exciting, implemented a support group for their peer mentors. They're encouraging more frequent supervision meetings with their peer mentor supervisors, and they've already reported that they're seeing benefits with this, with their peer support group, that they're feeling that increased support, increase in morale, and decrease in feeling of burnout. The last 2 here, collaboration, empowerment, voice, and control. We have a site that created a liaison position between mental health services and alcohol and drug services to get that mental health partnership and strengthen that partnership. All sites have noted now offering clients a choice of therapist. And then sites have reported changing in how they interact and talk with clients about some of the drug testing procedures. Lastly, we have a site who implemented a gender-specific therapist for seeking safety. So they have a women-specific group now for seeking safety to get to some of the gender issues there. Overall, our key lessons learned were that the use of peer mentors or recovery coaches was a crucial piece of being trauma-informed. They can really get to some of those triggers that we noticed throughout the site. The lack of mental health partnership was a key barrier that we noticed on all sites, so that's something to think about as well. Sites demonstrated an understanding of what it meant to be trauma-informed, but just didn't understand quite the how-to. So that was something we hoped that this action plan would help them to address. Need for information sharing agreements came up in all sites. Again, that was for that repetition of the intake and assessment questions. And the lack of multi-level training. So as I mentioned, the front receptionist or the janitorial staff or the security screens not having an understanding of training. So what I'll say is that with our work here in trying to make organizations and across systems become more trauma-informed, one thing that really came up was that it's not just the agency changes and organizational changes, but also those clinical interactions that need to change to be more trauma-informed. And that's where I'm really excited to pass it over now to Dr. Laurie Marcus, who will be going over some of the key competencies for trauma-informed interaction. So how can I speak to my clients in a more trauma-informed way. So we've gone over here the more organizational types of changes, and now Laurie will take it further and give some wonderful examples for how you can communicate better with your clients to be more trauma-informed. So I'll pass it off to Laurie. Thank you very much.
Hi. Hello. This is Laurie Marcus. So I am going to talk to you about the Institute for Health and Recovery, where I'm the Director of Trauma Integration Services. And what I'm going to talk to you about a little bit about our own systems change process and how from that we develop a number of resources to support both systems and practice change. So we started doing something similar to what Amanda and Vivian have just described in terms of a system change process. The way that we do it is that an agency completes a trauma integration self-assessment on their own, and then they choose a trauma champion, and that person develops a trauma integration team that includes people at multiple levels and all the different roles in the organization, from the receptionist to direct care staff to admin staff. And then we provide on-site trauma training for the team initially, and then that team goes on to develop a trauma integration implementation plan, sort of like what Vivian and Amanda were talking about called action plans. But we have a template for that, so it's like a workbook that they go through looking at all the different parts of what they do, from workforce development to service delivery to all different kinds of policies and procedures, and go through and develop goals and then begin to do the kinds of implementation that was just mentioned in the previous presentation. During that time, they can request additional training from the Institute for Health and Recovery, and that includes training on trauma-specific interventions. And then periodically, they repeat the self-assessment so that they can actually watch their own progress. In the process of doing that, we noticed that there were some things that organizations needed in order to become trauma-informed that we wanted to make more widely available when we weren't able to come on site. And this is a group of things that were collected into something we call the toolkit that you can order from IHR's website. So the trauma integration self-assessment is in there. There's also a staff practice survey, which is a survey that you can administer anonymously to your staff, and that measures sort of where you're at in terms of 6 domains of trauma-informed practice. That includes staff safety, staff empowerment, staff self-care, staff trauma knowledge and competence, staff attitudes, and trauma-informed practice. And then you can re-administer that after you move forward to see whether the training that you're providing is actually changing any of those things. We also developed trauma-informed supervision tools, because one of the things that we've been talking about is how do you really get penetration? How do you really get practice change? And one of the tools you have available is to do supervision. And supervision should, in a trauma-informed organization, should be done in a trauma-informed way. And so we have 2 supervision guides that are included in the toolkit about how to provide trauma-informed supervision and also how to encourage trauma-informed competencies in staff. And then we have these 2 tools that help organizations to implement trauma-informed supervision, and one is a supervisor self-check. So after you've done a supervision session, you have a way of looking at how did I do in terms of the trauma-informed competencies that I'm supposed to be exhibiting when I'm doing supervision. And then there's a supervisee learning review, so that for every staff member that you supervise, you can look at which competencies have they pretty much mastered and which ones do you want to be encouraging. And you can do that periodically. The toolkit also includes our template for developing a trauma integration plan, which is, as I said, like a workbook for the trauma integration team to use in talking about all the different aspects of the organization and what changes you might want to make in order to be more trauma-informed. So part of what we're talking about here is that there are kind of 2 aspects to trauma-informed care, and one is being a trauma-informed organization, and that involves a lot of institutionalization, policies and procedures, your physical environment, all of those kinds of things. But the other part of it is for staff to be trauma-informed and not just have a knowledge of trauma, as Amanda and Vivian both referred to, but actually know how to interact with clients in a trauma-informed way. So in the process of developing all of these resources, one of the things that we started talking about is what really are the core competencies for a trauma-informed workforce. And these are the 3 core competencies that we're looking at. How do you use an empowerment approach? How do staff build safe relationships with clients? And then how do staff both understand a client's behavior in terms of it being an attempt to cope with trauma, that certain behavior has developed as the result of trauma and the attempt to cope with it. And how does staff both understand that, and then how do you communicate that to clients so that they understand the connection between their behavior and their experience of trauma? So the first core competency is using an empowerment approach. And one of the things about this approach is, as Vivian said earlier, because trauma is an experience of helplessness, staff really want to help clients to begin to feel that they do have control and choice in their lives. And there's lots of things you can do to conduct interactions with clients in a trauma-informed way. One of them is to ask questions. So rather than telling clients what to do or telling them what you think, to ask pointed questions that help clients to self-reflect and come up with their own solutions and noticing their own observations of their lives. So this process can be used to help clients to identify in a particular situation what are their choices and what would be the result of making choice A versus choice B. So, if you're going to go to a residential treatment program, what would be the outcome of that as opposed to whether you're going to outpatient, things like that. All of their choices, thinking them through in terms of outcomes. And staff can help them do that rather than telling them what to do and what staff think the outcomes will be. So the idea here is for staff to offer clients as much choice and control as possible. A trauma-informed staff member is also going to focus on strengths. Trauma survivors know a lot and hear a lot about what they've done wrong in their lives, and they tend to focus that way. And a trauma-informed counselor will help clients to identify the skills they used to survive to this point in time so that they're aware of those skills and can now use them in new situations and feel more empowered in their lives and aware of their strengths and their skills. A trauma-informed counselor will also always notice very directly whenever a client makes a choice, even a small one, that demonstrates their capacity to lead toward their own goals. So every step they take should be pointed out so that they are able to see how they are using their choices to move toward their goals. A trauma-informed counselor will also be as transparent as possible, explaining why you're doing what you do, and what you're doing, so that there are no surprises. Partly it's because if you can't control the situation, being able to predict is the next best thing, and knowledge helps people to do that. So one of the trauma-informed core competencies is to be giving clients information so that they can use that information in the future in making their own choices. So now I'm going to show unfortunately I can't show you a video clip, so what you have is a still picture, and you're going to hear an audio clip of a session which is actually a role play. In this role play, the client, whose name is Karima, has just self-injured in a residential program, and I'm playing the counselor in the clip.
You felt pretty overwhelmed,
So
you actually made the choice that this might be the safest thing you could do.
yeah,
It felt like it was a better choice than you might hurt somebody, you might knock something over. So you actually thought about that, and I mean, that's pretty impressive. It's impressive that you were able to think of the things you didn't want to do and make a different choice. That's pretty impressive. That shows a lot of strength.
Thank you.
Really. So after you cut, after you used the fork, did that help you? Did you feel better?
Well, yeah, a little bit. I mean, I didn't have to, I didn't still want to hurt somebody else, and it kind of took my mind off of all that, and so I could stay here, so I didn't just get up and leave again like I did to other places,
So all those overwhelming feelings, all those things you didn't want to do. You didn't want to hurt somebody. You didn't want to knock the furniture around.
Right.
You didn't want to get up and leave. And so the alternative you could think of that would help you deal with the feelings was to use the fork to scratch yourself. Yeah, it's pretty amazing that you could make that choice, that you thought about what your best options were, and you chose that. That shows a lot of strength. So are there any, negative things about using that, cutting yourself? What's the downside of that? Is there any downside?
Well, normally, after it's over, a lot of times I have to, until they hear, I have to wear long sleeves and stuff like that, because I don't want people asking me, what's that? What happened right there? All of that stuff. So I just, I just keep it bandaged up, and I try and just keep this covered, and it's kind of uncomfortable in the summertime because it's hot, but.
Right, so you have to hide it. If somebody does notice and ask you about it, what's that feeling? What do you feel when somebody notices? Do you know?
I feel ashamed, and I don't know, sometimes embarrassed.
Why would you be embarrassed?
Because, I know that everybody doesn't do that, you know what I mean? So. But, it's been something all my life, but, I see people with tattoos or braces and stuff like that, and they don't have all that stuff and scars and stuff on their arms, so, sometimes I wonder, how's that going to look, later in life on my arms, or, will I ever stop that, and, how am I going to wear short sleeve shirts, and when it heals up, I know I'm black, but
right. So
but it's not gonna just disappear. So
so you don't really like having scars, and you don't really like people knowing that this is what you're doing. So those are the downsides. Those are the reasons why you might not really like doing this, and it sounds like you wonder if you're going to need to do it forever.
Yeah.
So first I want to say again that it's amazing what you're able to tell me. I just want to tell you that not every kid I talk to can even say I feel shame, can even name their feelings. So another thing, it seems like you're really aware of your feelings and you know how to name them. And it also sounds like you really think about what you do. So given all that, if we together could come up with other things you could do instead of cutting, maybe you would be willing to try them?
Yeah.
So you can hear how in that interaction, I pointed out Karima's strengths, and then knowing she had those capacities, talked about the pros and cons of the behavior. I was looking for her to express her own ambivalence, so that when I presented the possibility that that behavior could change, she would see that she might have the capacity to change it. The next trauma-informed core competency has to do with building safe relationships. So as we said earlier, a safe relationship is a collaborative relationship in which the client is the expert on their own life, and what we bring is our own knowledge and our own experience, but it's a partnership. And in order to have that kind of partnership, you have to be curious and open-minded. So you'll notice in that clip, you know, she's cut herself, and rather than my being freaked out or in any way, I'm asking her, does that help? And trying to find out what her own experience is. And I don't make any assumptions. I even say, is there any downside, rather than just, what's the downside? Because I want her to be the one who's making that assessment. You'll notice, you know, that I was also completely non-judgmental about her behavior and was trying to very much avoid shaming her for managing, for the behavior that she was talking about. It's important also for a trauma-informed counselor to be trustworthy. So you do what you say what you do. And it may take thousands of repetitions to break through the betrayal trauma that people have experienced in their past. You'll also notice that I ask a lot of questions about feelings and validate the feelings. And it's very important to do that before you move to behavior change, because clients have often not felt seen and heard. And if they don't feel, you know, in some behaviors are meant to communicate something, and if the communication doesn't get through, if clients don't feel like you're getting it, then they're not going to want to change it. But if they feel seen and heard and you validate the feelings and they know you've gotten the message, then they may be able to consider changing the behaviors. And of course, you know, the not being freaked out part requires me to use my own self-regulation skills. So whatever feelings I might have about the fact that Karima cut herself, I'm regulating enough to be calm and supportive so that she doesn't experience from me any panic or any disgust or anything that might make her feel badly about herself. So now I'm going to play another audio clip, and this is a client in detox, and we are talking about, so this is sort of doing aftercare planning with a client who is leaving detox. May we have the audio, please?
So yeah, I guess I'm going to have to try to stick with meetings. That's probably my best bet, even though I'm not crazy about them.
Well, wait, so you're saying that when you went to meetings, it didn't help you?
Well, no, not really.
Mm-hmm. And that actually going to meetings made you want to use more?
Yes. Yeah. Mm-hmm. But I don't know. You know anything? What else could I do other than meetings? That's what everybody says. Go to meetings. So.
Is there anything that you've ever done that you think did help you to stay sober?
Well, I used to be much more into staying fit and exercising, and I kind of let a lot of that go. I wasn't taking care of myself. So getting a good routine for staying healthy. Probably should go back to church, get some good morals, stay away from bad crowd, stay away from the party scene.
Mm-hmm. Has church helped you in the past?
It has. I've had good periods with it, but then I get mad because people seem judgmental a lot of the time, and they just sometimes I feel like I can't really relate too much to people at church. But if I meet somebody every now and then. I've been at churches where I meet maybe a couple of cool people, and I always seem to kind of get disappointed or disillusioned or something, or anger always seems to creep in there at some point.
Mm-hmm. And is anger one of the precipitants for your using?
Yeah.
Your drinking?
Yeah.
Yeah. So if you get angry.
Yeah, probably I probably should definitely do an anger support group of some kind.
Do you think that would help?
Yeah, that would probably help. I've never really done that.
Okay.
But yeah.
So it sounds like, you would like to have on your plan an anger support group. Maybe we could help you find one and make a referral before you go if you want.
Okay.
Sounds like you want to go back to church.
Yeah.
Any other supports you think you?
Well, my girlfriend can be a good support, as long as she doesn't get to nagging me, stuff like that,
Mm-hmm.
That always gets me. She can start, watching me like a hawk, and then I get irritated and start kind of trying to control my every move. Hopefully it doesn't go that way.
So it sounds like sometimes that relationship is good, but that there are moments in it where you get angry, and does that lead back to your drinking again?
Yeah, it is a hard relationship. I mean, she can be supportive, but then she can be really controlling too at the same time. So when she gets like that, then I tend to just say screw it, and try to tune out. So yeah, it can be that relationship can be a problem. So it's a bit of a risk, but at the same time, when it's good, it's good. So I'm hoping, I won't get into that negative pattern again.
So on a scale of 0 to 10, with 0 being you're absolutely certain you're going to relapse, and 10 being you're absolutely certain that you're not going to drink again, with that plan, going home to live with your girlfriend, maybe going to an anger management group and going to church, with that plan, how confident are you that you'll be able to stay sober? 0 to 10.
Yeah. Well, my track record isn't good, but I don't know.
Can you put a number on it, 0 to 10?
Okay, let's say 50-50, 5.
Okay.
Realistically.
So that's okay.
I mean, I know I'll do good for a while, but it just seems like something always comes and gets me, and I just get back into the negative thinking and drinking, and then it keeps getting worse. And it's hard to say with my track record that I won't go back, but I'm certainly going to try not to.
So can you think of any other possibilities of where you could go after you left here that might be better? I'm asking whether you would consider maybe going to some more treatment, something like a residential treatment program where you could live there and there would be, group supports, available to you.
Well, yeah, I mean, I'd be willing to do that if I'm going to try all these supports that you're suggesting, and I would say, if it's not going to be long until my girlfriend, she's not going to put up with anything, so I'd be willing to do that if I start to slip, but I'd like to have one more shot to do it right this time, do all the things I'm being told to do.
So I'm a little worried about 50%. So you almost died.
Now you just sound like my girlfriend. What is this? Come on.
What am I saying that sounds like your girlfriend?
Just nag. I mean, you're just saying, give me easy answers, and you're just saying, just look at the positive side, and just tell me what you want, what I want to hear. So, that's just, you just want me to tell you what you want to hear. I'm just be honest with you, 50-50,
No, I really do appreciate your honesty. I really do want you to be honest. And I hear that it's a little bit frustrating for you to have somebody sort of pushing at you a little bit.
Yeah. Well, you just seem like, you're just trying to get me to go to another program, and I'd like to tell you, I haven't had luck with programs. I don't think half the workers that are in these programs even want to be there. They all seem burned out to me. They go off and sit in the office and just leave us to sit here and stew in a room, and you just want to seem to want to push me into that kind of thing, and I don't.
Yeah, it feels to you like I'm pushing.
It does. Yeah. So.
Okay, so I want you to know that it's entirely up to you what you do.
Well, what are you going to do? Cab me over there?
No. So what I was thinking of is you and I can go over to the program, and I'll go with you. We can meet the staff. You can hear about what it's like, and then we can have another conversation like this. And I want you to know that it is totally up to you what you do. I just
You're saying you're going to go with me?
Yeah, I'll go with you.
Baloney. You're not going to go with me.
I'm going to go with you. I absolutely mean that. We're going to call the program and find out what time is good, and then I will go over there with you, and we will look at the program together. And then we'll talk about the pros and cons again.
So you can see in that interview, I had to use a fair amount of my own self-regulation skills, and also how much of what we came up with came from Steve as opposed to from me. So the Last trauma-informed competency has to do with understanding and explaining behavior in terms of past trauma and attempts to cope. So a trauma-informed staff member will ask questions that help connect behavior to adverse events and will understand and explain behavior as unsafe coping or attempts to survive rather than anything else, so that clients have some understanding about how it developed, and also because that's a less judgmental kind of approach. A trauma-informed staff member will recognize when someone is in fight, flight, or freeze and help them focus on self-regulation so they can think, and will teach and elicit self-regulation skills, and also help people to identify their own individual triggers. So I'm going to play one more clip for you. This is Tricia. This is her first outpatient appointment, and we'll see what she's talking about.
And I should tell you that, remember how I said earlier in the interview that people who've had adverse experiences like sexual abuse in their past or physical abuse in their past, that sometimes that's connected to what happens going forward?
Yeah.
Well, it's really common for girls who've experienced sexual abuse later in life to end up using or being in a position where they end up using that for survival purposes. So what you're experiencing is actually probably a lot more common than you think. But just like you didn't want to talk about it, the reason you don't know that other people are doing that is because they don't often talk about it. So that way you think you're the only one in the world who ever ended up in this position, and but in reality, lots of girls who've experienced sexual abuse grow up, and it changes, something that then, they end up putting themselves, they end up in situations. Now, obviously, you didn't create this situation, right? Your landlord is the one who is proposing to use his position of power to get you to do something that isn't what you want to do. And you're not responsible for his doing that. You're not. You're just doing what you've learned to do to help you survive. And we can work together for you to figure out what other options you have and what else you can do.
Okay.
Does that make sense?
Yeah.
Good. Thanks. Thanks for being so open. So are you ready to continue with the rest of the interview?
Yeah. So you can hear in that clip that Tricia reveals that her landlord is asking her for sex because she's unable to pay the rent. And then we have a conversation about the connection between that and her sexual abuse as a child. And if you'll notice, when I finish that conversation, the next thing I do after thanking her for being so open is to ask for permission to continue. So I'm checking in to see how she's doing and then to be able to complete the interview. The actual videos that those clips were taken from are available for free on the website, www.healthrecovery.org. And there will be a second video on trauma-informed supervision that I'm filming in May, so it should be out in the fall. And we will also have some online curricula for training the staff of substance about the connection between substance use and trauma-informed practice around that. There'll be 4 one-hour modules, and they'll be available in the fall as well. So that concludes my part of the presentation, and I'll turn it back to, I don't even know who, Melissa maybe.
Thanks, Laurie. This is Amanda. I'll jump back in. So I think we are ready to move forward to our question and answer section of, whoops, I skipped ahead too much. There we go. Q&A. So as Melissa mentioned to you earlier, you can feel free to type in any questions that you have into your question box, which is on the right-hand side of your screen in your control panel. So I invite you all to type out any questions you have there, and I will then read them over the phone, and I'll open up the phone lines for both Vivian and Laurie to respond to those questions. And several of our questions, I will say over the phone, several of our questions have been related to the PowerPoint presentation. And yes, it will be available online as well as the recording of this webinar within the next week. So you'll be able to access our website and gather the materials. We also put up the link to the video that Laurie just mentioned as well, so you'll be able to access that. I'll be sending out an email later today, so watch for that, and we'll provide all of those resources. So our first question, I will just go ahead and read, and Vivian and Laurie, I invite you both to jump in and answer the question once I'm finished reading. The question is, even though we have signed releases between DHS and the substance abuse provider, we are often given much resistance from the substance abuse provider to collaborate on care, even when establishing an aftercare plan. What are some ways that DHS could break through the substance abuse therapist resistance to use a team approach?
I'll jump in. I think one of the things is that you really want to get some of the directors sitting in the room as well to talk about how the collaboration can really be enhanced, and that if people aren't sharing information, even though they've signed releases, that it really is inhibiting the best approach for the clients. So, but I think that people need a discussion around what they're not trusting. I think trust and collaborations is one of those issues that's really important to keep talking about.
Yeah, I mean, I agree with Vivian. I think it's a lot about trust, and, you know, if there has to be a discussion about the fears. You know, I'm afraid if I tell you that she, you know, took one toke of a marijuana cigarette that you'll remove the kids again, or, you know, vice versa. You know, I'm afraid the client may be using and you're not telling me that, and that makes me reluctant to let her have more visits. So there has to be at the sort of, you know, you have to develop trust among yourselves that you'll be able to both, you know, to collaboratively work together, but, you know, based on the shared information about how to move forward. And when people feel that they really will be collaborated with, they're more likely to share the information. Next question.
Great. All right. So next question. How can we explain practices that are definitely triggering but are also necessary? For example, watching someone take a drug test.
Right. Well, one of the things is to explain that, you know it's uncomfortable, we have to do this, and how can I make it more comfortable for you? And if the person says go out of the room, you have to explain why you have to stay in the room. But I think asking that question constantly is how can I make this more comfortable for you is an important one. It gives, again, control back, even when the drug testing is mandated.
And you can also talk to a group of your clients about the drug testing and ask them for suggestions, telling them what your mandates are, and ask them for suggestions. So I've worked with programs where, although they're chain of custody urines, the staff member who is observing is actually watching a mirror as opposed to directly observing the client. And that's something that was come up with by the participants themselves. Next question.
All right. The next question I will go ahead and answer, and it was someone asking us what cities the walkthroughs were done in, and I will go ahead and give that information. And I do want to share as well that we have a findings report that we just finalized this week that we will be posting up on the National Center website, and I'll offer that the link to our website in our email today so that you can go and read the full report to hear the findings of the Trauma Walkthrough project. The 5 sites that we worked with were Robeson County, North Carolina, Dunklin County, Missouri, Sacramento County, California, Travis County, Texas, and Tompkins County, New York. All right, so I will move to the next question here. Let's see. Are there any outcome evaluations regarding trauma-informed care available online someplace that we can review?
Well, the Women with Co-Occurring Disorders and Violence study has many publications and outcome results, and they're up online. One site is the National Trauma Consortium, www.nationaltraumaconsortium.org. Laurie, do you remember other places where they're up on site?
Yeah, the main one I think of is that they're on SAMHSA's site under NCTIC, I think. I mean, I know they're on SAMHSA's website, but I think the part of it is the National Center on Trauma-Informed Care.
Good, good, yeah. So there are quite a few, and you may want to look at them. They're good results.
Right. Also, if you email me, I can send you a list of those references. I've got them in my computer.
Great. All right. Well, I will go ahead and pass it back to Sarah at this time, who is our last couple minutes here. Sarah's going to go over a couple of closing remarks and follow-up resources. Sarah?
Great. Thanks so much, Amanda. If we could move to the next slide, please.
Sure.
I'm absolutely thrilled on behalf of the New England ATTC to say that we've really enjoyed this conversation over the course of the last 3 webinars, and we're excited to continue the conversation at our first ever regional conference that's focused specifically on improving the care of adolescents. And our conference will address the care of substance use, HIV, and or HCV, which are all big issues nationally and are major SAMHSA priorities. And we'll be talking about effective approaches to assessing, treating, and engaging teens. And we will actually explicitly continue the conversation we've had today because Carolyn Castro-Domlin, who's a longtime friend and collaborator with the National Center, will be leading a workshop specifically on trauma-informed approaches to care as one of our breakout sessions in the afternoon. So this conference will be Thursday, April 16th, located in Connecticut. The information is here for you in the webinar. You can email me or call me with any questions. And if you go to the New England ATTC website, you can register directly through our website as well. And we're really looking forward to this and hope many of you will attend. Moving forward, I just want to emphasize again that this has been a wonderful webinar series and our first in the New England region of this kind. And then all the materials are available and along with the slides and the recordings on the CF Futures website, which is again listed here. The National Center folks and I are available if you have any questions. Melissa Lujan and myself have our contact information here if you have any questions specifically about any of the 3 webinars. And the National Center folks have also put together some really nice resources for you at the end of this slide deck. So if we advance forward, you can see some of that. As you log out of your survey today, you'll be directed to an evaluation, and we would greatly appreciate your time to please complete that, as that will help inform some future educational efforts that we might do in the future. And it also really helps us to improve what we're able to offer. And then as I mentioned, if you continue forward, if you download this presentation after this thank you, there's a set of resources for you that talk about some national and regional resources specifically compiled by the National Center about a range of topics such as some of their guiding principles and some of the resources that they have available for download on their website. So with that, I think that we are done with the formal presentation part of our webinar today. So we're really grateful for your time and participation, and it's been a delight to be with you all.
Thank you so much, Sarah. Thank you, everyone. Have a wonderful day.